One of the really important things, and we've referred to this from time to time so far, is about approaching this as a team rather than as an individual. If you are the only person trying to make the change, the chances of you making that change happen are slim indeed. Therefore, we need to try and work together as a team. Now, one of the big advantages of a team is that you will get a number of different perspectives on a problem if you involve people with different skills and different perspectives, and that in itself can be really helpful. One of the key reasons why we don't succeed in making change happen often is that we may have a very narrow view and narrow focus of what the problem is and how we can make that change happen. So going large and getting a number of people into a room to begin with to give you an understanding or a better understanding of what the issues might be from other people's perspectives may help really dramatically. So for example, and very simply, your perception of why a patient isn't getting to the angio room on time may be very different from the perception of the angio nurse or of the porter or of the ambulance driver. And if you have all of those people in the room together, you're more likely to get a much more comprehensive picture of what the issue is and how you're going to deal with it than if you just sit in a room on your own and think about what the solution to the problem might be. And it may sound obvious, but it's something we don't often do. Often we think of the solution to the problem rather than consulting widely with others about what that solution might be. The second thing is that the team you need depends to an extent on who it is you're trying to influence. And I've alluded to this earlier with the Health Foundation slide, but who are the people that you're trying to influence? Who else might need to know about what you're doing? So they may not be directly involved in the change you're going to make, but they may be a team that works with you. Important to let them know that something's happening so that they don't get upset about something that's changing in the system and they perceive to be a threat to their way of working, for example. Identify early on who the blockers are, because that's really, really, really important. And again, I said that earlier this morning, but again, I'll emphasize it. We all know there'll be one or two people, the naysayers, the people who are not keen to make change happen, the people who feel it's all hopeless, we can't make anything better at all. Identify those people at the beginning. Now, quite interestingly, often if you ask those people to be part of your team to make a change happen, you might well find a much more positive response from that person because they've been waiting for ages for someone to ask them to be part of the team, and they kind of self-isolate by having an extreme opinion and view about life. So bringing them into the team can be very helpful. If after your invitation they still don't want to be part of the team, well, you may have to set them aside. But trying to at least engage them and acknowledging that they may be blockers and therefore having a strategy of how you're going to deal with that is important at the beginning. And the patients and carers, I think, is really, really critical. And I'm going to spend a bit more time on that because I think that's another area that we probably don't do a lot in. So firstly, we might think, well, we're the only people we can have in the team. Who else is there to bring into the team? But there are resources around, and this may seem idealistic, but I don't think it is. You just have to make a bit of effort to recruit and find these people. The clinical leadership is really key, and I've emphasized that before, and I'll keep on emphasizing it. Without the clinical leadership, nothing much will happen. So you do need to find a clinical leader. If you're not a clinician, you need to find someone else. If you are a clinician, but you don't want to be that leader, you need to find somebody who's going to be the leader in your group, in your team, to take that forward. It's useful to have technical experts, so somebody who understands what's going on in that area. So, for example, I could be a clinical leader as a respiratory physician. My special areas of expertise are in COPD, but at the moment I'm leading the asthma audit. It doesn't necessarily mean I have to be an expert in asthma, but I might be an expert in audit methodology. But I need an asthma clinical lead who's going to give me that technical expertise. It may be a data analyst you need to help you understand what's going on with the data, or an audit specialist who works within your audit team who will help and work with you. But that technical expertise is important. And you also need a day-to-day leader, somebody who's going to do the doing. Now, you may suddenly groan when I say this, but often it's actually one of the nurse specialists. They tend to be much, much better at making things happen than the doctors. They're there more often. They're often very much more patient-orientated and focused. And often, like others, they've just been waiting for someone to say, here's a really bit of responsible work and we'd like you to lead on it, please, and give permission for that to happen. So it doesn't have to be that person, but you need a day-to-day leader, a doer, somebody who's going to actually make the program work. And then think about some of your additional team members who can often be people like trainees, but I'll talk about that in a moment. A project sponsor is helpful. Now, what do I mean by that? So I usually mean somebody who's on the executive team. So you might have a transformation lead, a chief medical officer, a chief nurse. There may be even a finance director who's really interested in your projects. It's going to save money for the trust. But somebody on the board of your organization who will give you that air cover. So when you come to the blocker, but when I went to speak to the data people, they said it's not a priority for them, you go to your chief medical officer and say, that's what I was told, what are you going to do to help me? And that person will then unblock. Now, I've been a board member on 2 acute trusts over many years, and I've been very impressed when clinical teams come and collar somebody on the board to be their sponsor, and it works really effectively. So if you've not tried that before, it's worth doing that. There always has to be a what's in it for me for the board member. So you have to engage with them. It has to be one of their problems or issues that they're trying to deal with that you need to try to be solving for them. But really do engage with the board members. It's really important. And what other resources might there be available that you can try and use as levers to get engagement? Well, most people, whether you're a trainee or a senior person, whether you're a nurse or a doctor, have to do some kind of CPD. And for most people, quality improvement is part of that. And every year, you have to fill in your portfolio and your folder to demonstrate you've done something. How much easier is it to do something here where it's all on a plate for you than where you've got to go and do your own project, where you've got to collect your own data separately, come up with some, as I've said, very small-scale program or process which makes very little difference to patients. But let's do something here. So let's engage people. Let's say as a department, this year, our department is all going to work on the heart failure audit. Okay? That's what our QI work's going to be. All of us are going to be signed up to do that. As a department, we agree. All the trainees that come through us, all our nurse specialists that come through, everybody is going to do the heart failure audit, okay? And you get that sign-up and agreement across the team. Each hospital will have 1 or more data analysts working in your hospital. You may not know that, but you will employ data analysts. Now, they'll be very busy doing lots of stuff, but again, if you approach them, they may be really interested. There may be some practical thing. Yeah, I've got a heart problem myself, or my mother had a heart problem, or my uncle died from a heart problem. Yeah, I'd really be interested in working with you on that. Bless you. So I think, again, you look for the various resources that might exist in your organization you may not be aware of, who might be very interested in helping with you. The audit department, again, this is a mandated national audit. Therefore, every trust should be putting resources aside to help support you collect data and analyze data and work in an improvement area. You will have an improvement team in your organization. It may be 1 person, it may be 10 people, depending on the size of your organization. They may have a very busy schedule, or loads of things to do. You may have to go and persuade them that hearts are really important. And to be honest, compared with lungs, hearts are much more emotive about getting people engaged. Patient stories, like the one we heard before, great way of getting people suddenly to sit up and say, yeah, we need to do some improvement work in that area. Oh, look, we've got all this data, so that's great. Oh, we've got a team of clinicians who are really keen to do something. Well, that's a win-win-win. Let's go with that, rather than go to that orthopedic department where none of the surgeons are interested in doing anything at all except making, sorry, I won't go on any more about that. I was going to say money, but about getting through their daily work. Let's work with the willing. So you've got a lot of traction, if you did know about it, a lot of capital there that you can use. And then there are other resources outside. Don't forget these. So NICE have an improvement team that work in every region on specific areas, and cardiovascular disease is one of their priority areas. So if you don't know about it, go and find your NICE team and see what resource they might bring in. British Heart Foundation, I haven't got them down here, but as you will know, have patient support teams who are very interested in working with patients to make improvements happen in the organisations that work in their areas. Talk to them about what they might do. The Academic Health Science Networks, and if you don't know what an NHSN is, you might need to Google it, but this is an NHS improvement funded initiative, have a national patient safety team in each one. There's a geographical one for each area of England, and they have a set of national priorities, but they are able also to help work with willing teams in organisations to make change happen in terms of improving safety to patients. And let's face it, cardiac disease, there's loads of stuff you can do about patient safety around that, whether it's moving from doing a femoral access to a radial access to all kinds of things, the right drug and not giving the wrong drug. There's a whole range of patient safety initiatives there that you can engage with. So I think the message is, look, you may think it's a desert, there's nothing out there, but actually there's 1,000 blooms coming up. You just need to look for them and open your eyes a little bit more to the resources that are available in the system for you. And finally, just a couple of slides on patients, because for me, this is the huge untapped resource. And just that straw poll around here confirmed that to me. Now, we don't have, we're all patients in a sense, and if we haven't been yet, we all will be, I can assure you. But we don't have particular patients in the room today with us now, and maybe we should do. But I can say these things. Sometimes clinicians see patients as the enemy. They're the problem. If we didn't have patients, we'd be fine. The patients are complaining about this. The patients want to do this, but I know the medical evidence says they should do that. What we have to do is harness and engage our patients and the public so that they work alongside us and look for synergies between what they require and what we require. Ultimately, both of us want better services for patients. So we need to engage them in that struggle. We need to think a little bit beyond, too, the patients we might have in front of us. Don't forget the voluntary sector. Again, British Heart Foundation, huge resource there. And I don't know how many of you work with your local officers and your local BHF groups, but if you don't, you should do. They can help enormously, huge amount of support and professionalism. Carers as well as patients, because they have a lot to add into it as well. And you may even want to go out and do public meetings where there are people who haven't yet come to you with their heart attack, but who know there's a high chance they will come to you with a heart attack, might be very interested in knowing that when they rock up at your hospital, they're going to get best care and not be in that sort of postcode lottery situation. So patient and public involvement is about really being real about it, though. It isn't about being tokenistic. So we do need to have a real mindset change. So they need to be part of your team, at your meetings, sitting down at the beginning, deciding what the issues are and what the problems are, not you presenting them with a solution that you thought of when you were having a shower this morning. It really is about getting them involved right at the beginning. Get them to think about how they might redesign or co-design with you a service or an issue or a problem or a pathway. And if you can then go back to your trust board and say, we've worked with patients, the patients have come up with these ideas which we support for change. It's so compelling. It's very difficult for a trust board to turn back to you and say, we're not interested. It really is compelling. Again, who here sits on a trust board? Okay, well, it's an interesting experience, but I can tell you, patients, as we heard, can get to parts that healthcare professionals can't get. They have a huge leverage at trust board level. So you need to have them there. You need to go and present to your trust board your plan with patients doing the presentation for you, and you just sitting in the background, nodding, and then taking the technical questions. So compelling. Boards find it very difficult to resist that kind of patient input. And you can get so much more from patients by, for example, that mapping process that we did there. So that was the medical mapping process. Ambulance called, comes to ED, seen by the triage nurse, calls the cardiac nurse, goes up. The patient's perspective of what happens is totally different. And there you'll come up with a whole range of things. I couldn't, the ambulance came, but I had to ring my mum first to tell her what was happening to me. So the ambulance had to wait 5 minutes while I called her because I couldn't get through to her, kind of stuff. All those kind of other things which go into a pathway which you'd never think of in a million years, but which you get the patient perspective will help you understand what's going on. And it's a lot more than this. So basically it's not, here's our plan, do you agree with it? Do you have any changes you'd like to make. It's about starting right at the beginning and getting the insight from the patients into your plan and getting the patients to be, in a sense, your main advocate. And if you're thinking to yourself, well, how do I get patients involved? You know, they, like me, are really busy people and they're sick people and they don't want to do this kind of thing maybe. Well, I think you heard how important it is to a patient to be offered the chance to be involved and engage. And not every patient will take it up, but even if only a small number do, that's all you need really to have a very compelling group on your team. So here's a few options for you. So on the day the patient gets discharged, why don't you ask them? Have a little piece of paper you hand out to them, you know, call this number or email this address or phone this for more information or whatever. Why not? Ask patients as they leave what they'd like to change in the system and what solutions they think they might have to those problems that they've come up. So you don't want just complaints, you want to hear some solutions as well. You know, create a "you said we did" board. That's quite a useful way of engaging people, and staff too. So, you know, patients told us they needed these things changing. This is what we did about it. And that makes everybody think that patients are important and gets them engaged. You know, how do you present your audit data to patients? Really important. These kind of things I've mentioned, the driver diagrams. We're going to talk about plan, do, study, act cycles in a moment. So that will become more relevant to you in a moment. What about running a workshop, getting a few patients together and saying to them, how does this work for you? And then getting that insight and then putting that into your improvement plan. And I know all of this takes time, but you will find there are resources within your organization whose job it is to do this kind of thing. And therefore you can link into that and get them to help you with it. You know, a patient vote, you know, how improvement, now you go to a supermarket and you get 4 tokens and you can put them into any box to decide what it is you think's the priority. There are a lot of ways of engaging people and patients want to be engaged in their healthcare on the whole. Most people do. So lots of little practical tips there, which came from patients, actually, about what they thought if only they were asked.